I am from Barcelona, Spain. I'm a member of the executive committee of the Heart Failure Association, and it's my pleasure today to be here with Lisa Anderson, the chair of the British Society for Heart Failure and NHSE Heart Failure Expert Advisory Group. And in the next minutes, what we're going to be discussing with Lisa is how we improve identification, evaluation, and treatment of heart failure. And particularly, we want to check what Revolution Heart Failure has provided us in terms of lessons and understanding of early diagnosis of heart failure. So what we're going to discuss today is about this, and remember that this is a session that's supported by an unrestricted educational grant of AstraZeneca. So these are our declarations of interest, and without further ado, I would like to start, Lisa, just by setting the stage on how natriuretic peptides are being used and how the diagnosis of heart failure is being conducted. There's a lot of evidence, and all this evidence has already been put in the guidelines. So when we look to the most international guideline, which is the Universal Definition of Heart Failure 2021, whenever there is suspicion of heart failure, this should be corroborated by elevated natriuretic peptides. It's very clear, it's in the center. We can go to other guidelines. We can go to 2021 European Society of Cardiology guidelines, the same issue, natriuretic peptides after suspicion of heart failure and before an echo. Let's go to the 2022 American guidelines. It's the same with a very clear 1A indication for diagnosis and monitoring using natriuretic peptides. Nevertheless, we are not doing very well following the guidelines, and we are far distant from what oncologists are doing. So when there is a clinical suspicion in cancer, everybody goes quickly to get an imaging test, do the biopsy, do the pathology, the molecular characterization, and start treatment. And that just takes days or maybe just a few weeks. When there is a clinical suspicion of heart failure, Lisa, the thing is completely different. We may do the ECG early, but then natriuretic peptides may take days or weeks or even months. And what to say about echo? I mean, echo may take months or years. So what are we waiting for? I mean, what are we waiting to do the diagnosis here? I am really surprised that nobody cares about this discrepancy, because the prognosis of many cancers is very similar to prognosis of heart failure. And in a way, I feel we are failing our patients. So what we put recently is a mnemonic so that all doctors can remember that whenever your patient is coming with fatigue or increased congestion or dyspnea, you should run a natriuretic peptide to rule in heart failure. So find HF. I mean, this is very easy. It's very easy to remember to perform a natriuretic peptide and do that. When we examined in an international survey of the Heart Failure Association of the ESC recently, these were responders of this survey. Responders are usually the most motivated. There is good access, 92% of natriuretic peptides in the emergency department. So that's pretty good. Not so good in the community, 34%. People think the evidence is strong. It's quite cost effective, but there are no structured pathways available in close to half of the cases. I mean, only 59% of the most motivated do have a pathway available. And this is something I would like to discuss with you later, because I think pathways are essential. So in summary, Lisa, what we get from the guidelines and we get from survey is that despite all the evidence, as you see in the right, there's only 1/3 of the participants, the most motivated, that do have access, that are aware and adopt natriuretic peptides in the community. So what are we doing wrong, Lisa? And what is the real world data tell us?
Yeah, so there's a growing data, a body of evidence from around the world, really. And this slide shows, first of all, some data from the UK. The CPRD database holds about 2/3 of GP practices, and over a period of time between 2010 and 2013, so it's a little bit old now. The really striking finding is that although we have had the NICE guidelines in place recommending NT-proBNP with the cutoff since 2010 at this point, only about a quarter of patients in the red circle were actually following anything like the pathway, having an echo BNP or echo and BNP and being referred to a specialist. So that was, just a quarter going through that way. Some people were getting a GP echo, some people were getting an NT-proBNP, or some people were getting a GP echo and NT-proBNP, but very few, only a quarter going to the specialist. And then right at the bottom, you can see that more than almost 2/3 weren't following any pathway at all. And what this was resulting in at this point in time is that, unfortunately, it was resulting in very late diagnosis. And it means that around almost 80% of people being diagnosed in the hospital. And this is despite the fact that they had been attending the GP, up to 40% or just over 40% of them had attended the GP with heart failure symptoms. So they're getting, little bits of the pathway, but not the full pathway. And they're not getting a diagnosis and they're ending up in hospital. And then there's also data from the US. The TriNeX NetX database holds about 124,000 patient data files from 52 organizations. And what that showed is that there's very little improvement over time. And when you look at the bottom of the slide, the percentage of patients being diagnosed as inpatients is growing in the US in this database over time. And the patients being diagnosed properly as an outpatient is falling. And the explanation for that is in the column graph above, which shows that in the community, over 30% of people are not getting any tests before they get a label of diagnosis. And even in the hospital, it's under 20% are actually getting a test before being labeled with heart failure. So we're just not following any kind of a pathway. Unfortunately, inside the hospital, this is really what to me was very shocking data from 2018. So a few years later now, in 2018, long-standing pathways, long-standing NICE guidance saying that we should be using NT-proBNP as the patient enters the hospital to get the diagnosis quickly. And this NCPOD, which is the National Confidential Inquiry, looked at every patient dying within a year. So that was 10,000 patients a year die with a heart failure primary diagnosis in the UK. And we looked at the 5,000 who died in the first week. And of those sickest patients, they were all really sick turning up to ED. Only 8.5% of them had NT-proBNP or BNP tested in the emergency department. And this results in poor care. So patients were given IV fluids, even once they'd entered the hospital. There's very low proportion of patients being seen by the heart failure team or reviewed by cardiology, and they get triaged to the wrong ward, so they have to be moved later on. So poor care in the hospital and outside of the hospital, and we're not following the pathways.
Yeah, right. I think, Lisa, that this is telling us that there's no emergency for diagnosis, and there's not such a need by the doctors to push for a concrete heart failure diagnosis. And I think that's what led to the Revolution-HF study, which you were a first author. And the Revolution-HF was launched because the signs and symptoms of heart failure are non-specific. We all know that. We know, as we already said before, that diagnosis is delayed. And this is particularly grave today that we have drugs to treat these patients early. So prompt identification is crucial. So Lisa, can you tell us a little bit more in detail what is Revolution-HF?
Yeah, so Revolution-HF is a publication based on data originating in Sweden. And we're very lucky in Sweden that the data is linked. So the data from GP practice links with specialists, links with the pharmacies, labs, and also with the ONS death records as well. So we can see everything about what's happening, and there's a good database. And we looked at a period from 2015 to 2020. And what we were interested in was patients presenting with heart failure signs and symptoms, so breathlessness or peripheral edema, and who also had an elevated NT-proBNP recorded within 30 days of those symptoms. And we followed those patients up for a year. And we compared those with matched age and sex matched controls who were also matched for where they were being seen in the community, whether it was a community clinic or whether it was in the GP practice. And they also matched by year and followed both sets of patients up to find out what happens to them. And we haven't really understood up until now what the outcomes are like for this population of people with suspected but not proven heart failure. And what we followed up over time was, really what's happening to these patients. When you compare the patients presenting with heart failure signs and symptoms, not surprisingly, they're going to have more cardiovascular disease. They're going to have an NT-proBNP, whereas they didn't have one if they were not presenting with heart failure signs and symptoms. But there's also more diabetes and more cancer, interestingly, in this patient group, slightly higher body mass index as well. And when you look at medications, not surprisingly, there's more of these patients on beta blockers and ACE inhibitors, and of course, loop diuretics than the control population.
So, Lisa, would you expect, or did you anticipate that the mean NT-proBNP would be so high in those patients with suspicion of heart failure? Because to me, this is particularly a high NT-proBNP to raise all the alarms and to ring all the bells. Huh?
Yes. Yeah. I mean, certainly levels over 1,000, these patients should be being fast tracked. They should not be sitting waiting for a long time to see a specialist or to get an echo. The very first piece of information to look at on this slide is to look at the spike graph on the right, which shows that actually the GPs were doing a fantastic job. The vast majority of patients were getting an NT-proBNP almost on day 0 when they presented with signs and symptoms. But then the referral and the onward care is very, very delayed. So the time to first echo, you can see dragging on very, very slowly over many, many months. Time to diagnosis, also there's a very, very slow, slightly better for the NT-proBNPs above 2,000, but still you can see that even by a 12-month period, for the very highest NT-proBNPs, less than 60% of them, or just around 60% of them, had a heart failure diagnosis. And overall, of all of these patients with raised NT-proBNP and heart failure signs and symptoms where the GP was suspecting heart failure, less than a third were diagnosed and received a diagnosis within a year. And the time from the index date, which was symptoms and elevated NT-proBNP, to echo was 40 days. So very, very long wait for the downstream diagnosis.
Yeah, this is particularly alarming because 40 days to get an echo means that the first registered echo means that probably there is no very clear structured pathway, as we said before. So the GPs do perform quickly the NT-proBNP, but in a way, to me, it looks like they don't really know what to do after they get the NT-proBNP, because with that, if with the suspicion and the elevated NT-proBNP, you would already consider these patients to be able to be treated, then things would be different. But probably that I am a bit puzzled by this slow conduction of echo. Huh?
I think it's not also necessarily the GP's issue. The GP may well be referring. So in the UK, we've had a nice guideline telling us that if your NT-proBNP is elevated and you have heart failure signs and symptoms, that you should refer on immediately, and you'll be seen within 2 weeks for NT-proBNP over 2,000 or within 6 weeks for NT-proBNP over 400. But if those clinics are not in your area, if there's no pathway, then you just send a referral to general cardiology. That's going to sit in the bottom of a queue and wait many, many months like everything else. So not necessarily the GP. It could be that the secondary care system has just not taken this on board and they don't see this as a priority.
Yeah. I didn't want to blame the GPs at all. I wanted to blame the whole system, the whole pathway. Huh? So this is what the revolution tells about treatment. Huh?
Yeah, so this is really interesting. You can see that the GPs instinctively really felt this was heart failure. You can see that when you look at the loop diuretics, there's an instant increase in loop diuretic prescription. So they've got a patient with heart failure signs, symptoms, they've got an elevated BNP, and they're starting to try and treat these patients to improve their symptoms. However, they're not sure. They don't have a formal diagnosis. So when you look at what the GPs are doing with beta blockers and RASI, that's very disappointing. And MRA, even at the end of the year, you can see, less than 10% of patients on an MRA. So in terms of actually treatment that's going to change the outcomes for patients, this is incredibly disappointing.
Yeah, yes, because we know loop diuretics are good to remove congestion, but they do improve evidence to reduce outcomes. And Revolution did provide us some of these. Huh?
Yes, and not surprisingly, when you look at the hard outcomes for patients, so if you're presenting to the GP with heart failure signs and symptoms, you've got an elevated BNP, and yet nothing is happening apart from maybe some loop diuretics, this is what happens. So in the first slide, you can see that's the hospitalizations for heart failure. You can see that presentation, particularly with a very elevated NT-proBNP, is essentially a sentinel event. This is an emergency, because by about 2 weeks, you're approaching 10% admission rate. So you have to really move quickly for these patients if you want to prevent an admission. And you can see that as the NT-proBNP levels fall, you can see that that's less pronounced, but there's still all along this, all these patients with elevated NT-proBNP and heart failure signs and symptoms, there is a hospital admission risk from the point of presentation. And that, of course, we know that in the UK, certainly there's around 10% mortality if you get admitted to hospital. And you can see in the second graph that all-cause death steadily increases, obviously highest in those with the highest NT-proBNP, but there's a steady increase in death that carries on through the year. So this is what it looks like when you don't have pathways in place to rapidly diagnose patients and get them on really disease-modifying medication really early on.
Yeah. Let me just stay a few seconds more with this slide, because to me, this is very impressive, because we do have now drugs like SGLT2 inhibitors that have proven evidence that, for example, in the liver and in emperor preserved, that the graphs diverge significantly over the first 10 to 20 days. So very, very early, we get the benefit of these drugs. So it looks to me that even without having an echo, with suspicion and elevated natriuretic peptides, and let's remember that we said before that the mean level was 1,500, it looks like a very large number of patients would have benefited from these drugs very, very early, in addition to loop diuretics. What do you think?
I do think, but I think also, unfortunately, that GPs are inundated. They lack the expertise to really sort of take these decisions without clear guidelines in place. And so you need to have a clear guideline to the GP saying, if you suspect heart failure, this is what you must do. If that's not there, even if they feel it might be the right thing to do, they're probably not going to do it. And you can see that they're happy to try and do something to help. They are giving diuretics. And diuretics are not without risk, particularly in older, frailer patients. So that they are happy to take action, but they will need guidance. And unfortunately, say in the UK, SGLT2 inhibitors are only recommended by NICE to be given for heart failure once the diagnosis has been made and once it's been directed by a heart failure specialist. So until you see a heart failure specialist, the GP would have been acting outside of national guidance at this point. So there are a lot of barriers that you would need to address in order to see really sort of disease-modifying medication getting to patients quickly.
I understand that, and the same thing happens in Spain, and I believe Revolution should be an eye-opener for many regulators in different countries, that probably GPs and pathways should be working together with hospitals to start not only SGLT2 inhibitors, but there's which are 1A indication in guidelines today, so they should be implemented. of course.
Yes, I mean, I think that these slides are very important for anybody who is trying to get change in their localities, because everybody's hospitals are full. Nobody can afford a full hospital. And I think when you show what's happening to these patients, and if you intervene more quickly, what you could actually prevent, and that the gains that could be made in a healthcare system if you actually had rapid pathways in place, that's really very convincing evidence to show to commissioners to try and change things and to try and get these pathways set up in your locality.
True. And what all this information tells me is that when there are already signs and symptoms, and you have all this molecular evidence of myocardial stress and strain. So at the end of the day, natriuretic peptides are just released when the myocytes are under pressure, and that the higher the levels, the more pressure this myocardium is suffering. This should be already enough to start treatment, and echo should come afterwards just to phenotype particularities, whether it's REF with very reduced ejection fraction, whether it's hypertrophy, it's amyloidosis, and so on and so forth. But we should be able to move quicker and in a way copy our oncology colleagues to get treatments started quickly. Because as you said, once the patient is in the hospital, we know that admissions go with mortality, and means that we have failed a little bit to our patients before preventing their admission. But let me ask you about the whole concept of natriuretic peptides and age and so on.
Yeah, so there was some interesting data here, which I wasn't aware of before. What you can see is that NT-proBNP, whether you're male or female, there's almost a linear increase in your risk of either heart failure hospitalization or death until you reach the level of around 2000. And then it seems to angulate and almost plateau. Certainly for women, it almost plateaus the risk of heart failure hospitalization, apart from in the very highest elders group, where you see that there is a sort of slowly increase in hospitalizations. For men, there's less of that plateau, and I don't know what's behind that. It's very interesting that they look slightly different. For all-cause death, however, the graphs are essentially the same. You can see that there's quite a steep increase in risk, whatever the age, until you reach the level of 2000. And then the level still increases, but not at such a fast rate as the NT-proBNP increases beyond that point. So 2000, interestingly, appears to be an interesting cut point, and it wasn't something I was aware of until I saw this data.
So in a way, it looks very clear that 2000 is the high risk limit, and this 2000 is already a very red flag. But probably there's a need to better characterize age-adjusted cut points, and in that regard, we are working into that, and there is a consensus from the Heart Failure Association that is proposing adjusting for age, and there are 3 strata: below 50 years, 50 to 74, and 75 and above, with values that says below 50 years, the cut point would be 125, 50 to 75, 250, over 75, 500. And these values are taken from Scotland generation cohorts, the 95th percentile above normal population. And what we know from many years already is that with age, natriuretic peptides go up, and we need to adjust for age. I'm uncertain, and I would say I don't think we do need to adjust for sex. We have done some analysis, and looks like probably we do not have to adjust for sex. We know that natriuretic peptides are sensitive to other issues, for example, kidney dysfunction. We know that when there is CKD, levels go up, and certainly if they go up, we probably shouldn't adjust cutoffs for CKD. And the only issue that we should probably consider is obesity, because in very obese patients, particularly obesity type 3, those patients with a body mass index above 40 or even above 35, it is true that the levels are reduced, and are reduced by almost 40%, so almost half. So this is work in progress, and what is very clear from Revolution to me is that 2000 is a high risk cut point, and below we are just trying to understand if we need to age adjust or not. You guys in UK use 400 as a single cut point.
400 and 2000. So above 400, 6-week clinic, and above 2000, it's a 2-week clinic. But those clinics are not in place in many places around the country.
This 2000 is very clear, and we put here priority echo and evaluation 2 weeks, as you have in the UK. This was written in 2023. Today, I would probably put a different time frame. We would have to get a consensus here. And for the age adjusted above these cut points, we say here treat as appropriate, considering that above and beyond diuretics, we should add SGLT2 inhibitors. You should add probably an MRA and then arrange for an echo. These 6 weeks, Lisa, what do you think about these 6 weeks? Would you still keep those, or you would go?
I think you need to prioritize on the how high the NT-proBNP is, and I think having a 2-week slot for patients with the highest NT-proBNP is absolutely essential. And if you're going to start anywhere, that's where you need to start. It's unfortunate if your NT-proBNP is 1900. You might end up waiting 6 weeks, which is not great, because we can see how steep the risk climbs as the NT-proBNP rises.
So